Stress fractures are a common yet often misunderstood injury, especially among athletes and military personnel. These fractures occur when normal bone is subjected to abnormal, repetitive loading that exceeds the bone's ability to repair itself. Over time, this leads to microdamage and eventually a fracture. Unlike acute fractures caused by a single traumatic event, stress fractures develop gradually, often presenting as localized pain that worsens with activity. Women, particularly those involved in endurance sports or with a history of menstrual irregularities, are at higher risk. Understanding the basics of stress fractures is crucial for early recognition and effective management. In the next scene, we'll explore the risk factors and underlying causes that make some individuals more susceptible than others. The development of stress fractures is influenced by a combination of intrinsic and extrinsic factors. Intrinsic factors include personal characteristics such as previous history of stress fractures, low bone mineral density, hormonal imbalances, and body composition. For example, women with low energy availability, menstrual dysfunction, or low body mass index are particularly vulnerable. A condition known as the female athlete triad or REDIS. Extrinsic factors, on the other hand, involve external influences like training intensity, type of physical activity, inadequate rest, poor footwear, and even the running surface. Both sets of factors interact, increasing the risk of microdamage to bone. Recognizing these risk factors is the first step in prevention and early intervention. Next, we'll discuss how stress fractures are diagnosed and classified. Diagnosing stress fractures involves a thorough approach, starting with a detailed history and physical examination. Patients typically report localized pain that worsens with activity and may be accompanied by swelling or tenderness. Imaging studies play a crucial role in confirming the diagnosis. While X-rays are often the first step due to their accessibility, they may not detect early stress fractures. Magnetic resonance imaging, MRI, is considered the gold standard, as it can reveal bone edema and subtle changes days after symptoms begin. Other tools like computed tomography, CT, and bone scintigraphy may be used in specific cases. Laboratory tests, including vitamin D and calcium levels, are also important, especially for recurrent cases. Accurate diagnosis ensures timely and appropriate treatment, which we'll cover in the next scene. Managing stress fractures requires a multidisciplinary approach tailored to the individual's risk factors and the specific site of injury. Most low-risk stress fractures are treated conservatively, beginning with rest from the offending activity for 6-8 weeks and gradual return to exercise. Pain management, physical therapy, and alternative low-impact activities like swimming or cycling can help maintain fitness during recovery. Nutritional support, including adequate calcium and vitamin D intake, is essential. For high-risk fractures or cases with delayed healing, advanced therapies such as bisphosphonates or anabolic agents like teriparatide may be considered, though more research is needed. Prevention focuses on education, gradual increases in training, proper equipment, and screening for risk factors like the female athlete triad. By understanding and addressing both intrinsic and extrinsic risks, athletes and clinicians can work together to reduce the incidence and impact of stress fractures.